Can I also invite Lewis and Ian to join us for the end session? So if anybody does have any questions for us, please do put them in the questions and answers. The first question is from William Seller, who's asking, saying that myasthenic patients often have bulbar problems, difficulty in swallowing and choking, shoulder ache and headache due to holding their head up, and often unsteady gait. And I would completely agree with this. I think the patients I was talking about in my talk are the ones that just have ocular myasthenia before they are generalized. And I think these are a very difficult group to sniff out because often they just have a little bit of intermittent double vision. They can mimic an INO, they can mimic a cranial nerve palsy. And of course, it can be a variable squint that they present with from either the beginning or the end of the orthoptic assessment, or actually the beginning and end of a month or a week. So I think that was the ones I was talking about, not the actual generalized, who obviously have difficulty with swallowing. The next question talks about how you tell a decompensating phoria in an eye exam as against a neurological cause of diplopia. And I think this is a very interesting question. Often neurological causes for double vision have very little on cover test when you look at them, but a decompensating phoria will actually show itself on cover test in the primary position often. For instance, an INO can have a very small exophoria, but quite a big distrugate movement. A phoria can also, if you measure it and it is decompensating, the fusion range is often just on the cusp of controlling it. So when it's a nice, bright, sunny day, a patient with a large exophoria has a slightly larger fusion range and they can control it if they're well rested. But if they're actually getting over the flu, they're feeling tired, it's a grey day and the children are misbehaving, their fusion range goes down a little bit and they get their double vision. So I think actually looking at the primary position, thinking about how much fusion the patient has, and if the eye movements are conjugate and the same phoria in all positions of gaze is very useful. I don't know if you'd like to comment, Sema.
You're the expert. We go to you, Liz. So that's absolutely right.
Well, maybe this is one you can help with. Somebody's asked, would you scan a person older than 60 years with diplopia who has no vascular risk factors? I think I'd definitely do an ESR, and I think it depends on the onset. If the onset is still very quick and they know exactly when they happened, it's probably still vascular. So maybe we should test them for hypertension, which of course can be high at only certain times in the day, diabetes or high cholesterol. And then also the history. But if none of those are present, yes, I think we would investigate these people thoroughly. What do you think, Sema?
I think I agree. I think sometimes there's a tendency to over-investigate as well, you know, and so one's got to be careful. But as you say, if there are no risk factors, then I do think that we would all be saying, well, you know, what is the cause? We've got to look a little harder.
Excellent, thank you. Now we have one last question, and it's about a specific patient, and it's a case of intermittent binocular double vision. I think, yes, it's an esotropia and an esophoria, and it's a gradual onset of a year. The patient's been investigated for myasthenia and thyroid, and this has been excluded. So what are we thinking about? Does anybody want to help out on this one? Okay, I'll have a crack then. Yeah, I think the most important thing is to ask if the patient is very short-sighted or over -5, probably more like -10, because then they can very easily have a distance esotropia, which is associated with their myopia and then not a sixth nerve problem. You really want to think about whether they have got lateral rectus, because of course, what I'm worried about here is the slow growing chordoma that just very slowly and insidiously gives a sixth nerve palsy, and looking for an MRI scan just to look for that, as well as other things that can give you that ESO problem. Sema, do you want to add anything?
No, I really don't. As I say, I think that what is really important is to involve the multidisciplinary team. And of course, people like yourself, Liz, being an orthoptist, you know, this is your bread and butter. And sometimes we struggle, you know, well, what's going on? And as I said from the beginning, be humble and just ask and say, please, I can't quite put everything together, but I know there's an abnormality here. You know, do we need to do something? So I definitely think things in the casualty department that pertain to neurology, you know, are very difficult for us.
And having good links within hospitals and good pathways to that neurological team when you need them, and the Cornell team, as we've seen tonight, is worth its weight in gold. Are there any more questions for the whole panel, or any questions from the panel to other panelists? I'm very aware that it's only me between you and your weekend. So what I think we ought to do is thank the speakers very much for their expertise and a really entertaining webinar tonight. Thank you for that. Thank you to the audience for giving up your time on a Friday night, and particularly the members of SOE that have made this webinar happen. It doesn't just happen by magic. There's been a lot of hard work from the team with Joe, Hannah and Anne. And thank you so much for the people at Talking Slides for making the magic happen. Today's webinar will be on the SOE website very shortly. And I would really like to wish you a very happy and healthy weekend. And there are just 3 questions that we would very much like you to answer on leaving the webinar. So thank you very much for your time. And it seems appropriate to leave you with a Zoom wave, and hoping that we can meet face to face very soon in the future. Thank you.